Well, good day. I'm Lieutenant Colonel Stephen Leighton. I'm currently the head of CAP Health Services at the national level, and I'm here to present an update and a discussion about the role of health services as it's evolving in Civil Air Patrol, along with a presentation on the new position of Mission Health Service Officer. So I'm going to go ahead and share my screen, which will enable me to go through these notes with you effectively and bring you an update on health services. So again, that is me, and this is my contact information, which will be repeated at the end of this program. And I encourage any health service officer or commander with interest in CAP Health Services to contact me with any questions or concerns. So let's begin and take a look at our agenda. I'm going to be talking about the evolution of the National Health Services Program. I want to share with all of you the developing cooperative and collaborative relationships with both safety and the chaplaincy, and then share with you some of the silver linings, as I call them, and the lessons that we learned during the last 2 or 3 years as health services played such a vital role in how Civil Air Patrol responded to the pandemic. And then finally, we're going to go through fairly briefly a presentation put together by Lieutenant Colonel Robert Ditch about the Mission Health Service Officer in the Incident Command Post. So let's proceed forward. The Health Services Program is continuing to professionalize and is aiming towards a truly consistent both health information, education, and health services delivery product. As you all have heard over the course of time, we have revised and have proposed a new draft updated health service regulation, which will become CAP Regulation 79-1, which remains in coordination but is pending final approval, and I have it on good authority. It's very likely to finally complete that process this year. Along with it, we are instituting a health services professional development pamphlet with specialty track guidelines. Those will be released with the regulation. And along with that, we will be developing and uploading a series of modules into Axis that will facilitate the progress of health service officers moving through the ratings in health services. Along with this, we're also developing a library of health and wellness briefings that will complement work being done on the safety side. And we're updating or have updated the health services forms. You all are familiar with the CAP Form 161 and the like. We now will be having a CAP Form 79-1, 2, 3, and 4. 79-1 is Cadet Health Services, past history, medications, current problems. 79-2 is the same for senior members. 79-3 is a form that incident commanders and activity directors can use that is a self-assessment of a member's fitness level to ensure that they're not put in a position that would be unsafe for them. And 79-4 is a form that can be used to capture and record first aid episodes for the purposes of record keeping in health services. We have created a series of working groups. Many of you know about them to address significant areas for further developing the health services program. And we have substantially expanded the role and the integration of health services into all of CAP's missions to America. And finally, as mentioned earlier, this last year in 2022, we began to develop an increasingly close collaborative and cooperative relationship with both the safety and chaplaincy directorates. That has been an impressively fruitful coming together of these directorates. As some say, we're breaking down the walls of the silos and already have contributed together with safety on the new safety dispatch and with the chaplaincy on their new approach to resiliency. And I'll speak more about those in a little bit. The establishment of the working groups has been aimed at developing some important areas of health and safety within CAP. So I'm going to outline a bit for you here of what some of these working groups have been doing. We've activated, for the first time in a long time, the Health Services Advisory Team. The advisory team consists of the region health service officers and a number of ad hoc members who have been very active during the course of the pandemic over a 3-year period of time, meeting almost always on a weekly basis. We've reviewed all of the remobilization plans that have been submitted by activities and wings during the pandemic, and we continue to work on evolving health services and Civil Air Patrol in a variety of ways. We're working on developing the health service officer training curriculum. As I mentioned earlier, we're talking about a curriculum that will be uploaded in large measure into Axis for convenient completion and be accompanied by experiential and service opportunities. We're professionalizing the specialty track, so it's really going to be a major improvement in the status and the position of health service officers and allow us to finally make use of this as up till now fairly unutilized resource within Civil Air Patrol. Again, we're developing the new Mission Health Service Officer position, and I'll elaborate on that thanks to the help of Lieutenant Colonel Robert Ditch on exactly what that position will look like. We're anticipating that the training for this position will be a significant training opportunity for health service officers and take them into realms that many of us may not have actually experienced before. We are utilizing existing training in every area from health planning and public health emergencies and more. Increasingly, the role of the health service officer ties into the public health arena in providing advisory capacity to command at all levels. We're creating a curriculum in aerospace physiology, particularly for aircrew members. And we have a working group that is looking at disaster and epidemic preparedness. The intent of that working group will be to develop action plans and resource materials so that CAP doesn't have to reinvent the wheel each time we have a new serious incident that comes along. We'll be prepared to adapt these prototype action plans to meet the need. We have established or are working on establishing a partnership with the National First Aid Training Organization, and in particular are looking at a DoD program called TCCC as a potential resource for standardizing first aid training across the organization in a way that would be very inexpensive and very effective for the membership. We're creating best practice models that wings can use in developing their encampment health services based on the extraordinary work done on several different wings in developing programs that really meet the need of the cadets and the staff at encampment. And there's more. This is a very busy slide, but let me run through it quickly. These are the 5 primary areas in Civil Air Patrol and areas that the Health Service program contributes to. Cadet programs looking at physical fitness mentoring, health promotion, reasonable accommodation. Emergency services in the red circle on the left, medical planning, training health service officers to work together with safety officers to put together an effective ICS 206, first aid, CPR, and AED instruction, qualified in general ES and encouraged to go beyond. And then this is the area where the Mission Health Service Officer will begin to provide an extraordinary service to incident commanders and activity directors. In the safety area, we are already collaborating with the safety officers in a variety of ways. I'll speak to that more in a little bit. In education and training, we are developing through the specialty track guidelines, the necessary professional development program for health service officers to move into the technician, senior, and master levels. We are participating in developing resiliency and CISM training for our membership, and of course, health promotion for seniors. And then in AE, the SUAS and aircrew health checklists, aeronautical briefings, fit for flying lectures, and things along that line that will contribute to the health, well-being, and safety of our members as they work in that area of aerospace education. So let's look at the collaborative culture that has been developing between health services, safety, and chaplaincy. You know, in the past, both safety and the chaplaincy were well established and very well recognized. They weren't challenged and questioned in the same way that health services has been. Health services has been relegated to a rather minor role in many areas, oftentimes in the shadows and very definitely behind the scenes, or limited to things like training members in first aid for the purpose of getting their ES ratings, not really for the purpose of making sure that our membership was actually and adequately trained in first aid. We're changing all of that. Now together, these three directors address the overall human systems aspect of Civil Air Patrol. We are working together to enhance the health, wellness, and safety of Civil Air Patrol members in a variety of ways. So I'm going to look right now at safety and how we are cooperating with safety and developing an expanded, more effective risk management program for Civil Air Patrol. The Safety Directorate is a program manager, but isn't actually an expert in all areas. And this is true in industry as well as Civil Air Patrol. Health services complements safety, doesn't replace it, but complements it, in particular in the areas of injury and illness. Because if you think about it, many hazard mishaps involve physical health and physical injuries, and health service officers are uniquely positioned to be able to advise safety in how to effectively put risk mitigation and management measures into effect. There's a recognition of a need for a closer coordination between all the directorates, and that's really come out as health services joined with safety in the new Safety and Health Services reformatted dispatch to replace the safety beacon. Our health service officers are already supplying articles each month for the dispatch, and we welcome health service officers around the nation to reach out and contribute articles, and they're welcome to send them directly to me at Health Services, and we will prepare them for use by the dispatch staff. The future of the safety management system with CAPSIS, continuous improvement, use of lessons learned, Health Services is working to help complement their efforts to make it an effective program. Now let's look at the chaplaincy in health services. Thanks to several of the chaplains, in particular Chaplain Michael Morrison, resiliency and post-traumatic growth have become an aspect of the evolution of the impact of the chaplaincy on health, on Civil Air Patrol, and Civil and Health Services is joining with that effort in a collaborative committee to develop the programs that will be instituted throughout CAP. We're increasing the training in psychological first aid for health service officers, utilizing the expertise in the chaplaincy and looking to them for guidance there, and also in critical incident stress management, where the CISM officers complement what the chaplaincy offers to our membership. So I'd like at this point in time to look at some of our silver linings. Let's look at some of the beneficial outcomes that took place during the pandemic. All of us discovered the effectiveness of virtual conferences and meetings. Our health services advisory team meets on a weekly basis and has for 3 years. Instead of our members having to travel and take enormous amounts of time out from their personal lives and other CAP activities, an hour a week, and we've been able to accomplish a tremendous amount. There's been an increase in accessibility for the broad membership. So that virtual meetings at wing, regional, and national levels have taken place. Many of you probably participated in the national conference 2 years ago, a year and a half ago, that went from 800 in person to over 10,000 participants virtually. We're doing the same thing within the health services arena. The Region Health Service Summit with the Rocky Mountain region had quite a participation virtually as well as in person. So health services has evolved into a central role as one of the primary advisors to national, regional, and wing leadership in the area of health services, of mitigating risks, of helping to educate our membership in how to stay safe, to stay healthy. There's been a dramatic increase in the awareness of the principles of contagion and infection and the role of public health measures in general disease prevention. Yes, there's been pushback, and yes, many of us are tired of wearing masks and having to put in place some of the other protective measures. But we've learned from what's often called the Swiss cheese model, where if you add this mitigation and that mitigation and several others along the way, you end up with an overall effective program. We're now at a point where we're looking back and considering what have all the recommendations we put into place, what difference have they made in the safety and health of our membership? Well, it's interesting if you really take a look at it, that the experience in Civil Air Patrol has been substantially better than that of the general population. Our members have in fact stayed healthier. There's more knowledge out there concerning the spread of infections on different levels, from the touching of surfaces to the respiratory inhalation, to different things that we can do as a population, as humanity, to cut down on the infectiousness of various and sundry infectious organisms, and to increase our resistance through vaccination and appropriate medication and other mitigation procedures. We are developing some clarity around the role of things like face masks and other non-pharmaceutical interventions and why they work. And I think now that humanity has a much broader perception of what a pandemic really is and why it's important to effectively respond early in such events. In this country, we had an interesting experience when our initial response was somewhat tardy. Even the CDC was a bit behind the curve. And as a result, we probably experienced a greater spread and a more rapid spread of the early pandemic, COVID-19 pandemic, than we might have had we really been fully prepared for it. And in Civil Air Patrol, that's what some of our health services working groups are doing right now, is preparing the way so that we can move forward much more effectively at the early stages. Part of that is developing familiarity with disease metrics. So whether you're looking at the online programs from various universities or elsewhere, you have an idea of what's actually happening both on a regional area, but also in your own local environment, your county, potentially in your city, and you can learn to expect what kind of measures would be appropriate to put in place for various activities and events. Silence is golden. One thing I came to recognize many years ago, I did a fellowship in family medicine in Chapel Hill, and my area was health promotion. And one of the things I came to recognize was that successful health promotion, disease prevention and safety is nearly always silent. There's very little accolades and blowing of horns and celebrations when we don't experience some of the negatives that can result from inadequate prevention. And yet, when we fail to follow the safety regulations, the public health recommendations that are put out, even if they're put out in a delayed fashion, we end up finding that tragedy occurs, things which might well have been avoidable. Examples like people who are in a hurricane, in the way of a hurricane, and draw the conclusion in their own mind that they'll just ride it out and come to regret that later on. Well, the same thing is very much true for infectious disease and other types of health risks and health damages. So here are some lessons learned from the pandemic. All across National Command, we became aware of the need to balance safety with the need to keep our ES teams adequately trained and prepared to carry out our missions for America. It wasn't enough to just put the entire organization on a lockdown. We had to figure out creative ways to allow our air crews to continue to maintain their skills so that they were ready to respond to emergencies as they came up. And that's true across the board. We also learned about COVID fatigue. Just when it's at its worst is when we need to double down and keep our eyes on the prize. This is something which, when looking back into the lessons in history, we even saw in the 1918 influenza epidemic, where the third year of the epidemic, almost every area in the country had dropped their restrictions and their lockdowns, and they saw the highest number of infections taking place during that period of time, simply because everybody had relaxed their concerns. We've probably seen the same thing happening in China and several other countries around the world. And these are things which into the future, we may actually be able to work with more effectively. We've had a chance to have debates and discussions about what readiness really means. How do we maintain readiness? How do we keep our membership active and involved through a crisis like a pandemic that may last over the course of months and even years without losing their edge? And of course, the necessity for effective and timely communications. This is my year for really expanding communications, which is one of the reasons why I'm doing this recording right now. I want to make sure that our membership is clearly aware of what's going on in health services and how they can contribute. So we are reaching out to our wing health service officers. We have a solid crew of regional health service officers, and we want to expand that down to the squadron level so that the lessons, the training, and the messages of importance get out to every member in Civil Air Patrol. All right, at this point, I'm going to shift to look specifically at an incident commander's perspective on the new Mission Health Service Officer position. This was a program that was put together by Lieutenant Colonel Bob Ditch, who many of you may know. He heads up the Pulse Lift program. He has been one of the foremost in educators in NESA. He runs the mobile training team. And Dr. Bob, as he likes to be called, actually put in place Mission Health Service officers during several of the hurricane response and recovery periods, utilizing health service officers with solid skills to help advise and work with incident commanders to effectively respond. This is a little something about Lieutenant Colonel Ditch, Doctor of Education, Professor of Disaster Medicine, Homeland Security, Health Services and Emergency Services. He's been around for years and has done an extraordinary amount of work in the area of emergency health services. So let's begin with what is the Mission Health Service Officer and what is it not? What it is is an occupational health and safety advisor to the incident commander and the incident management team staff and the mission. What it is not is a clinician or public health official only. In Civil Air Patrol, many of you are aware that health service officers are limited clinically to providing first aid. We are not diagnosticians. We are not prescribers of medication and treatments. We intervene at a first aid level, but we become an expert in advising command on how to prevent injuries and illnesses and how to set preparations in place so that we can respond to the injuries and the illnesses that do take place. Here's an overview of the incident command structure. At the top, you have the incident commander and his or her deputy. You have direct reports in the mission safety officer and the mission health service officer. Mission chaplains and public information officers also report directly to the incident commander. In addition, the mission health service officer provides medical intelligence to the intelligence and investigation chief, as well as technical expertise to the planning section chief. So the responsibilities of the mission health service officer include senior advisor to the incident commander in what are often called occupational health and safety matters. And that is truly a broad sphere. Again, it's not diagnostic and it's not prescriptive. It is much more in the area of public health, mitigations, risk management. Mission Health Services planner, educator, and custodian of records. Demobilization lead for health services, making sure at the end of a mission that significant issues aren't lost because people simply headed on home. So there's screening that leads to appropriate release and appropriate follow-up as needed. These are all in the responsibility area of the Mission Health Service Officer. So the MHSO is a health services educator, a post-mission occupational health analysis and analyzer, and provides a vital service and expands the effectiveness of the incident management team. So to look at a few aspects of this, the incident in the face of a significant incident, there's an initial response analysis and assessment. And there are several things that go into this initial assessment that involve skills that a mission health service officer has. We're looking at the nature and the magnitude of the incident, the hazards and safety concerns for responders and the public, as well as those directly involved, initial priorities and immediate resource requirements, and the underlying endemic epidemiological threats and risks. Those are the things in the environment that affect and influence our ability to respond effectively to whatever the disaster or incident is and to the effects and the harms that have resulted from it. For that assessment, a clear understanding of the incident is critical. In many cases, an incident commander would not necessarily have the background and skills to take a look at and recognize the potential for health risks and health harms. There are many factors to be considered when performing this assessment: situational awareness, incident complexity. All of these things come together so that a comprehensive grasp of the incident is available to the incident commander. So there's a step in situational awareness that it's worth looking at briefly. Perception leads to gathering of information through observations and communication, which enhances our perception and identifies further areas of information gathering necessary, which then extends out to those who are doing the observations with their feet in the field, and communication from them back to the incident team. Then from there, from that level of perception, it goes to comprehension, which is influenced by the individual, the incident commanders, and his or her staff's perceptions, past experiences, training, and of course, the changing environment that's evolving right in front of them, but it leads to an increased level of comprehension. From comprehension, we project out to identify what can be done, what are the appropriate responses, and that leads to the loop of perception, comprehension, and projection, and that continues to evolve as we go through the incident and the recovery period. So the incident response analysis leads to preparedness. The disaster or emergency incident and the potential effects. In many cases, it may be things like high winds or flooding or power outages. In the case of a pandemic, it could be, again, the spread of disease, individuals becoming increasingly sick, overwhelming hospital resources, and of course, those, if there's a high mortality rate, even overwhelming the ability of handling dead bodies, and leading to potential harms, injured, sick, dead, and missing. These are all the kinds of things that can result during any kind of serious incident that we're trying to respond to. So that leads to a response. You have the incident, you have the effects and the endemic factors, that's the environment, the resources available, all those kinds of factors which fit into the incident management team's assessment that also lead to the harms and then lead to factors which affect the probability of control of the incident. By that, we mean, what are the impacts to life, property, the economy, environment, as well as the individuals, community and responder safety, potential hazardous materials and environments. How do we factor that into how we effectively develop our strategy, which leads to our tactical response? Weather and other environmental influences, and the likelihood of cascading events, secondary and tertiary effects from flooding and the like that could have an impact, again, back on the community, on responder safety, and would alter and require an adjustment in our use of various and sundry resources, factors, and planning. So there's an operational period and a planning cycle in incident management. If you start at the bottom on the right-hand graph, you see the incident notification, the initial response and assessment, all leading all the way up to the initial briefing for those who are going to be in command, the United Command meeting, where they develop a strategy identifying who's in command and what is the staffing and what are the kinds of risks and issues that we need to prepare for. After that strategy meeting, you'll see highlighted on the left the role that the Mission Health Service Officer participates in: tactics meetings, planning meetings, completion of the incident action plan, operational briefings, and demobilization. This is a vital role. So we're going to take it a bit at a time. The incident briefing, the purpose is to provide the incoming IC, whether it's at the beginning of the incident or a change of incident commander, with sufficient understanding of the incident and the response needs. Attendees would be the IC command and general staff. The facilitators, the current IC or planning section chief. Move on to the tactics meeting. Difference between strategy and tactics. Strategy is the overall picture. Tactics are feet on the ground. What are we actually going to do? Determining how to accomplish the strategy, assigning resources to implement the tactics, identifying methods for monitoring the tactics and resources, the utilization of tools such as the ICS 215, and these are meetings which occur prior to then the actual planning meeting. The Mission Health Service Officer, along with the Mission Safety Officer, it requires a front row seat because they're intimately involved in the developing of the tactics which will lead to the planning. Planning meaning then is the purpose and the opportunity to review and validate the operational plan as proposed by the operations section chief. So this is where everyone vital to the incident management team has the opportunity to speak up and contribute. In the agenda, we have a number of items. I'm only going to highlight number 5 and number 9, where the mission health service officer, along with the mission safety officer, plays a significant role. So we want to look at health and safety mitigation measures that need to be implemented along with other tactics and appropriate resources. And then communications in the medical and area in particular, the mission health service officer is responsible, again, working along with the mission safety officer to ensure that medical and health issues are addressed in terms of communication and logistics and planning. So the incident action plan is then developed from the planning meeting, and it communicates the incident commander's requirements in terms of force protection, safety, and accountability, the effectiveness of the response operations expectations. It's a feedback loop. We want to find out if what we're putting in place is working as planned. It's operational directions for incident response, and that's the who, what, when, where, and how that we're involved in as a mission, as an incident command team to respond appropriately to the crisis. Details on medical health care and access and care are a part of that incident action plan. Again, the incident action plan components include 3 areas where the mission health service officer fits in particular, the ICS Form 206 that many of you are familiar with, along with that, the ICS Form 208 that we can contribute and work together with the safety officer on, and then the 215A, which is the incident action plan safety analysis. That may be, it's a worksheet, but it allows us to develop what goes into the medical plan and the safety messaging and plan. So this is just what the Form 206 looks like. Again, many of you are quite familiar with this. It provides information on incident medical aid stations, transport services, hospital, medical emergency procedures. It's how do we respond to the inevitable injuries, illnesses, and challenges. This is an extremely important form for a health service officer to know how to complete, and we will on Axis eventually have an effective training program to make sure that every health service officer who's going to be involved in an incident command team will be well-versed in how to complete this, the information they have to gather, how to fill it out, and how to make it available to the incident management team. It includes health force protection measures. That's down, if you look at the number 8, special medical emergency procedures. What are we going to put in place? What do we have to have in place for this particular incident to make sure that we're keeping our members, our health force safe? This is prepared by the mission health service officer, reviewed and signed by the safety officer, so they collaborate together to make sure that this vital form is as effective and complete as we can make it. Along with that is the ICS Form 208. This is under the primary responsibility of the safety officer. And of course, the mission health service officer can add into this to help the safety officer identify situations such as stress, dehydration, fatigue, distress, concerns over lifting, tripping hazards, et cetera, that our members could be exposed to during the incident response. So it's supporting tactics, health force protection measures, but as Dr. Bob emphasized in his presentation, this is not a novel. This is a focused safety message that specifies specific things that everyone involved in the response needs to be aware of and how to mitigate the risks and hazards that have been identified. The operational period briefing is an essential place for the mission health service officer to contribute to. And then finally, at the end, we look at demobilization. So what's the tendency? The tendency in those involved is, hey, time to go home. We're out of here. got to get out, get out of my way. I'm headed back to where I have to come from. Well, that's a prescription for potential disaster. The demobilization, the ICS 221, is actually should be under and will be under the control of the Mission Health Service Officer. It's the demobilization is recognized as the most hazardous of all the phases. There's a widespread hurryitis syndrome that inevitably accompanies demobilization. Our role as Mission Health Service Officers is to slow things down and make sure that we cross the T's and dot the I's so that we're ready to send our members back home safely. It's the time when the work of both the Mission Health Service Officer and the Mission Safety Officer increases exponentially. We have to be using this form and identifying and following up on exposures, injuries and illnesses, safety health incidents discovered during and from the incident itself. So just because we're demobilizing from the incident itself doesn't mean that our work is over. And for the Mission Health Service Officer, it goes on and continues on into the days and weeks after the incident to make sure that we stay on top of, follow up with everyone involved to identify things that might be risks that need to be addressed. So I wish I was there to answer any of your questions. And I'm hoping that we have health service officer and individuals with the incident command teams in your area available to work with you. My contact information is here. Anyone is welcome to email me at slayton@capnhq.gov or my phone 336-529-0383. I welcome calls from anyone who needs assistance in clarifying how to respond to a given situation. I appreciate the opportunity to have a chance to address you. I'm going to stop the sharing now and simply say that health services has and continues to evolve. It is becoming a vital part of Civil Air Patrol, all of the work that Civil Air Patrol does, and together with safety and the chaplaincy, is focused importantly on taking care of the membership. We want to make sure that our cadets and our senior members stay safe, stay healthy, and can move forward and continue to be effective in responding to our missions to America. So on that, I'm going to bring this to a close and say again, I really appreciate the opportunity to address all of you. Have a very good day. Take care.